Today we will address evidence-based medicine. Clinicians should use best evidence to consider these consequences for clinical decision-making. Thus, clinical epidemiology and evidence-based practice are closely linked. Clinical epidemiology grounds healthcare research in the mission to deliver optimal care to individual patients. As it turns out, clinicians optimally applying the best evidence to their patient care must understand the basic concepts of clinical epidemiology. At the same time, while clinical epidemiology grounds the clinical investigator's viewpoint, evidence-based medicine provides the framework for application of research findings in clinical practice, including a framework for clinical decision-making. Evidence-based medicine evolved out of the efforts of clinicians with research methodology training, that is, clinical epidemiologists, to apply their particular insights and approaches to solving clinical problems. In contrast to the traditional paradigm of clinical practice, evidence-based medicine acknowledges that intuition, unsystematic clinical experience, and pathophysiologic rationale are important but not as sufficient for making the best clinical decisions. Although it acknowledges the importance of clinical experience, evidence-based medicine postulates that optimal clinical decision-making requires the integration of this experience with the circumstances, setting, patients' values and preferences. An estimate of effects of interventions or diagnostic strategies. In 2002, Haynes and colleagues described a model for making evidence-based clinical decisions. That model focuses on evidence as research evidence and requires an integration of other factors to make the best decisions. Since then, the field of practice guideline development has led us to develop an extended model of evidence-based decision-making. In that model, as seen in the figure, there was increasing recognition that clinical expertise is an overarching pillar of supporting best decision-making, but that these decisions should be based on the best research evidence. The better recognition of the importance of patient state and circumstances as well as values and preferences supplemented the original model. However, the emphasis was on research evidence about effects, and a clear delineation of what constitutes evidence to support decision-making was missing. Evidence-based medicine places a lower value on authority than the traditional medical paradigm and explicitly includes patients' and society's values in the clinical decision-making process. Patients or their proxies must always trade the benefits, harm, and cost associated with alternative treatment strategies, and in doing so must consider values and preferences. To achieve the integration of research results in clinical practice, evidence-based medicine proposes a formal set of rules to help clinicians interpret and apply evidence. Clinical epidemiologists have by and large developed these rules, but they have been refined in the 2 decades of evidence-based medicine. These rules are characterized by a hierarchy of evidence. That is, the confidence in research results is greatest if systematic error bias is lowest and decreases if bias is more likely to play a role. However, they have moved from simple, now outdated hierarchies as shown in the figure to balanced approaches that include considerations about the evidence. Although randomized and controlled study designs provide the highest quality of evidence from a perspective of single studies, evidence-based medicine is not a science of randomized controlled trials. Rather, because higher quality evidence often is not available, evidence-based medicine acknowledges that a large body of highly relevant evidence comes from observational studies. That is, to answer clinical questions, clinicians will often depend on observational studies in their evidence-based practice. Therefore, the practice and application of evidence-based medicine requires an understanding and critical evaluation of all study designs. In a further evolved model for evidence-based decision-making, increasing emphasis is placed on the recognition that evidence about the various factors that influence decision-making can come from various sources, and that a single patient in the clinical decision-making context provides evidence about her own values, which requires integration with other pieces of evidence. Without doubt must the highest demands made toward obtaining any evidence with methods that are least vulnerable to bias. This new model also includes considerations about the best implementation and knowledge integration methods as a critical part of medical decision-making. Using research evidence to guide clinical practice requires formulating sensible clinical questions. For most questions, the key components are the patients, the intervention or exposure, comparison interventions or exposure, and the outcomes. Population or patients means who are the relevant patients. Interventions or exposures means what are the management strategies clinicians are interested in. For example, diagnostic tests, drugs, toxins, nutrients, and surgical procedures. Comparison or control intervention or exposures means what is the comparison, control, or alternative intervention clinicians are interested in? For questions about therapy or harm, there will always be a comparison or control, including doing nothing, placebo, alternative active treatment, or routine care. For questions about diagnosis, there may be a comparison diagnostic strategy, for example, troponin I compared to creatine kinase MB in the diagnosis of myocardial infarction. Lastly, outcome means what are the patient important outcomes of the therapy, diagnostic test, or exposure clinicians are interested in?